Today on Community Connections, we're going to be talking about the Wound Treatment Center over at Monmouth Medical Center. I'd like to thank Dr. George Fahoury and Dr. David LaPorta for coming over from the Wound Treatment Center over at Monmouth Medical Center. Tell me what that is, because it sounds like it could be almost anything.
The Wound Treatment Center is a specialized center for people, for whatever reason, have a hard time healing chronic wounds.
Who would that be? I mean, we were talking before, frequently diabetics?
Most frequently they are diabetics who can have problems with their circulation or with numbness, tingling, or altered sensations in their feet.
But it can be any patient that has a wound that just has not responded to treatment.
What would cause that? I never having had something like that, and I learn about illnesses when a family member has them. And nobody's ever had something like that. Who's likely to have a chronic wound?
Well, any patient can have a chronic wound. It depends on the etiology of it. Some patients have poor circulation. There's not enough blood for it to heal. Like Dr. LaPorta just stated, diabetics have poor feeling, so that constant pressure keeps it open. Infection. Patients have traumatic wounds that are extensive damage, and they're not getting, it requires more advanced care than what they're getting. I mean, there's a number of reasons. One of the main assessments that we do with wounds when they come in is the etiology.
So somebody comes in with a chronic wound, first thing is you get the complete medical history and you find out diabetic or something else. Is this common from an accident, or is it mostly there's going to be a long-term care issue?
What causes it?
Yes.
Usually it's not from an accident. Usually it's more of a longer term
What
issue.
is it about diabetes? I mean, because it happens to run in my family. I don't have it, but I've got a family history of it. What is it about diabetes that causes a chronic wound?
Poor sugar control is the underlying factor. People that don't take care of their diabetes, keep their sugar checked, check in with their internist or diabetic doctor. As your blood glucose levels are higher and abnormal, there's more nerve damage.
And then they don't have the feeling, and they get the injury, and it doesn't.
Correct.
They don't know they don't even know they have it sometimes.
Correct.
The injury.
Yeah, that's correct.
What kind of injuries do you typically see with someone who's got the poor circulation and the lack of feeling? I assume in an extremity most of the time, or at least first.
It can be anywhere there's pressure. You know, a lot of times, patients just, they're not, like I say, have great sensations at the bottom of their feet. Certain pressure point areas will break down very quickly on them. Diabetics typically have, like I say, poor response to infection. Their immune response isn't the same. Their tissue isn't as strong. A lot of times they've developed a type of neuropathy that makes their skin dry and less resistant to pressure.
What's a neuropathy?
How the nerves are affected.
So,
if you think about it, a lot of diabetics can't feel their feet. So it's a natural reaction. When they go to the shoe store, they look for that tight-fitting shoe so
really?
they can feel the pressure.
Something as simple as that?
Feels, yeah.
Which is actually going to cause...
So are we talking something that might start out as a simple blister?
Correct.
And then it just never heals, and it gets almost like a bed sore. It just gets worse and worse and worse?
Correct.
Absolutely.
Correct.
Because bed sores, if you've ever had somebody in the hospital for a long period of time, you get familiar with what they are. What does the treatment center do for them? If I come in and I say, I've got this large blister that just won't go away, what are you going to do?
Well, initially they get a full history as to their past medical, surgical, allergies, a full physical examination. try and determine the etiology of the wound based on history and physical examination, appropriate consultations, need be, whether it be nutrition, circulation, neurologic testing, infectious disease, a basic assessment of the wound, and then develop a plan individualized for that particular patient, because no one wound is the same.
But what's going to happen to them at your place? Say you determine they need the kind of treatment you offer. I mean, my first question is, what's the machine look like?
Which machine? Hyperbaric?
Hyperbaric.
It's actually, it looks like
There's more than one machine, I take it, from that answer, though.
Modality of treatment, you mean? Yeah.
Okay.
Yeah, there's a variety of treatments. Hyperbaric chambers, which you were referring to, it's actually a long, clear tube that the patient actually breathes forced oxygen, saturated oxygen.
Similar to an MRI tube?
Kind of, but fully sealed and
Sealed
pressurized.
and closed.
So I lie in a tube, something close to my face, which...
Not close.
No.
You can watch TV, listen to the radio.
Yeah.
So it's fairly comfortable.
Fairly comfortable.
How long am I in there for?
Average 40, 45 minutes.
Now, is the oxygen being absorbed into the body through the wound, and that's what makes it helps the healing process, or is it the deep breaths and you're getting the oxygen into your system and it's being dispersed through the lungs?
It has to be absorbed systemically. You have to raise the level, the tissue level of the oxygen in the blood, which then goes into the tissues.
So it's just a matter of being in the tube and breathing the air.
Correct.
Now, how is the air different than, say, this air in the studio or the air outside? What makes it different?
Oh, the analogy is, think of it this way. We call them dives. It's the same analogy of a scuba diver. You're increasing the pressure, so you're forcing more oxygen into you.
Why a tube then as opposed to a mask? Comfort?
No, these are like decompression chambers,
Right.
if you've seen them on TV.
Okay.
You can't raise the pressure on a mask.
All right. But I'm still trying to figure out what they look like. I mean, somebody can go in, they're in this tube. Is there a TV right in front of them and you got cable and I can...
There's a TV on the wall. You could speak with the attendant. There's a microphone.
Oh, you watch it through the tube. It's a clear
Absolutely.
tube. It's like...
There's a microphone.
What's it made out of?
Pressurized glass and steel.
How long have these been around?
They've been around for a while. There's actually different varieties of them, but for a while.
What other... You mentioned that you said what machine, so there's more than one type of machine that they might use for this? If I come in, hyperbaric chamber isn't for me. What are the other options that you offer?
Other modalities?
Modality meaning what? You're using all these fancy words.
To heal the wounds.
Okay.
Yeah.
Well, like I said, you have to do an assessment, and you know, hyperbaric is just one small piece of the assessment. Lots of times these wounds have a lot of necrotic tissue that has to be cleaned up.
Necrotic meaning basically dead.
Yeah, and they may be in a stage where they're like stalled, and they'll need certain advanced wound care products that'll jumpstart the wound. We also have engineered tissue products where you can put them on there. We also have actual human equivalent skin products that can be put on there.
So this is a pretty advanced, I mean, wound treatment, you're trying to stave off, ultimately, an amputation, because, I mean, that's one of the big risks with diabetes. You're going to lose a toe, a foot, or a leg.
Correct. 85% of the amputations, losing your leg in the lower extremity, are preceded by a diabetic ulcer. So if we can get that ulcer closed...
The ulcer's the wound.
Correct. Then, you know, patient quality of life is much better, and we can stave off that amputation.
How does somebody get in to see your office? Would I need a reference from my primary care physician, or is it a little bit more open than that?
No, you can just call the number, and you make an appointment just like you would make for any physician's office.
And then you come in, and the process starts. What other kind of wounds are you treating there? Or is it mostly we're talking skin wounds?
Well,
Or is it all...
They can be skin wounds down to bone that involve bone, infections in bone.
Is that what would lead to the amputation? The wound has spread to the bone and it's just at that point not going to be cured?
It can still be cured, even if it's in the bone.
What do you do then? Is it the same course of treatment?
Well, it may involve surgery. It may involve other procedures. The hyperbaric chamber is actually the perfect indication for a chronic bone infection. Mm-hmm. Again, that oxygen gets deep down into the tissues and deep down into the bone where the bacteria are.
What does the oxygen do? How does it work? I mean, it seems like such a basic treatment. Okay, breathe oxygenated air, as opposed to, it's not a medicine, it's not an antibiotic, it's not chemotherapy, it's breathe better. How does it work?
Well, by increasing your tissue levels of oxygen to your extremities in your body, you're getting more blood flow into the area to fight an infection.
Okay. Is that kind of similar? I mean, an Achilles tendon doesn't heal quickly because you don't get blood flow there the same way you do to other parts of the body.
Correct.
Correct.
And is it sort of the similar thing when you have something on an extremity, it's just a little bit harder and somebody who's got diabetes is a little less healthy?
Correct.
Yes.
How long has the wound center been there?
At Monmouth Medical Center, we started in 1999 as an outpatient facility. Or was it? No. When did we move to the hospital? I think it was 99. 1999 we moved to the hospital. We started prior to that as an outpatient facility.
Meaning that you weren't quite connected to the hospital or got referrals from the hospital, but now you're part of the St. Barnabas system.
Yes.
How many doctors work there?
Well, we have 2 podiatrists. We have a general surgeon.
All right.
We have a vascular surgeon.
Or does it rotate, or is it the same person?
No, the same doctors.
And who are they?
That would be Dr. James Roros is our general surgeon. He takes care of all of the decubitus wounds that occur on the back and the hips and other areas.
And then you were saying you had a vascular surgeon too?
That's correct.
And who's that?
That's Dr. Constantinopoulos. He also does venous closures on people who have venous insufficiency, and that's another cause of wounds.
What is, you use all these...
Okay, yeah. It's the venous system. What happens in some people is the valves are incompetent, so it lets the blood drift back, and that increased pressure will cause a wound to occur over certain particular areas of your lower extremity.
Is that also related to frequently to diabetes, or is that something a little bit different?
It's more related to somebody who has an insufficiency of their venous system and is long-standing.
What is a venous system?
Well, your veins.
Oh, okay. So it's just you have a circulatory problem that has to be treated.
On the venous side, correct.
Okay. Is that also, I know that Dr. Constantinopoulos also treats aneurysms. Is that at all related to any of this, or not really?
No.
That would be something completely different. How many patients do you guys see in a year over there? How big is the operation?
It's a big, multifaceted operation. We see both outpatients and inpatients from the hospital.
Where physically on the grounds is it located? So is it, I can get there internally?
The 255 entrance, right across from the train station.
All right. We're going to take a quick break, and then we're going to come back for the second half of the show.
This is fine. Thanks.
Back with Dr. George Fahoury and Dr. David LaPorta from the Wound Treatment Center over at Monmouth Medical Center. One of the things we were just talking about on the break is one of the things you can do is skin grafting. And the skin, the skin that you're going to put on somebody is sent to you in the mail.
Real skin.
Real skin, but it's grown in a lab.
Yes.
How does that happen? I mean, I'm a lawyer. You know, these things. I never. You know, science was something I avoided as much as I could in college.
Well, as Dr. Fahoury alluded to, they're called human skin equivalents, which means it's actually both the first two layers of skin, epidermis and dermis. And in the old days, where they would have to take a graft from your backside or your thigh, involved hospitalization in an operating room, we actually pick up the phone when appropriate, and we order this skin graft.
1-800-SKIN?
Something like that. And it's sent in the mail.
Where do you get it from?
From the lab in, I believe, Massachusetts.
Is there more than one outfit that makes this, or you've got one place that you go to and they've got
No, it's a
medical
pharmaceutical
patent on
company.
it?
Yes.
There's two companies that actually produce these products.
One's designer and has a label on it, and the other one's a little bit more generic, or not
No,
quite
they're
that
both
fancy?
designer. They each have their own different characteristics.
And what makes one different from the other? Anything in particular, or?
One is what they call bilaminate. It has the epidermis and the dermis, and the other one just has the dermis.
And I would guess, I'm assuming the nature of the wound and the severity of it dictates what I would need. And what is a skin graft? I mean, you don't just place a layer of skin on the wound and let it grow, I'm assuming?
Well, actually, with this human skin equivalent, we refer to it as a human bandage because it's done right in the wound care center. You don't even need an anesthetic. Once the
Like a Band-Aid?
It's placed on basically with different types of fixation. Fixation
means some sort of glue?
Glue, steri strips, some sutures.
And then what do? You just leave it there and it grows in and
it incorporates.
And it adheres. What does it look like?
A piece of skin.
Color?
It's pinkish in nature. When you talk about a skin graft that lots of times surgeons will do, they'll take the top layer of the skin off, and you'll have a donor site that you have to deal with that's got to heal and will tend to scar.
Fair enough to think that's a dangerous thing for a person who's got these kind of problems?
Well,
it's another procedure.
It's another risk, yeah, it's another procedure that you have to deal with. Those actual skin grafts that you take from one contralateral leg to put on the other leg actually have to take. In other words, the blood vessels have to grow into it and it has to stay viable. This type of human skin equivalent actually gets absorbed in, and it utilizes all the growth factors and other...
Reduced risk of infection also.
Well, yeah, because you don't have a donor site. And it's so-called, like I said, jump starts the wound healing.
A lot less pain, too, for the,
Correct.
for
There's
the
no
patient.
pain.
Correct.
How long has this been around?
For a few years now.
A few years, 5, 10, or even?
At least 10.
What's the name of the company that manufactures it? Do you know?
Organogenesis.
That's interesting.
And the product's known as Aplograph.
Somebody comes in and they've got a moderate wound. How long are they going to be coming in? I mean, is this something where they need this oxygen for the rest of their lives?
No, just to help with wound healing.
And how long, is there any sort of average patient you can talk about, like from the time he comes in, when they would anticipate how long they'd have to become seen? They'd have to come see you?
Well, initially it will probably be weekly. The wounds are measured, they're photographed, and we can assess healing in that way. And if one modality is not working, then we'll go on to the next modality. That just makes the whole process more efficient.
Skin grafts would be a more serious form of treatment than going into a tube and breathing air. Is that a fair assessment?
It depends. A lot of time they're used
Not necessarily.
together.
Okay.
Yeah. These are all, there's no one treatment for this.
The patient who comes in, how much of it can they control? You know, how much of it is they're not taking care of themselves and need to do a better job than that, of that, and how much of it is they're past the point where they can just sort of control through diet or exercise or other? I mean, diet is what you typically hear for a diabetic.
Well, like Dr. LaPorta alluded to, a lot of the complications from diabetes is directly related to how well they control their blood sugars. There are tests that their internists run to see over a period of time how well they're controlling the sugar as opposed to just an instantaneous test, and they can tell if they're taking care of themselves. But how their immune system functions, what degree their blood vessels and nerves are affected are directly related to how they control their sugars and also how they heal, how they eat, if they're getting a proper diet and they have the proper minerals, whether they're staying off of it. A lot of these patients tend to continue to walk and not really offload some of these wounds. A lot of the healing has to do with what they do when they leave our wound care center.
Do they get, is there a physical therapy element to it, or not really with you guys?
No, just different offloading techniques.
Offloading, meaning what, just stay off your foot?
Well, yeah, it could be that simple. Different types of fabricated boots, different type of healing shoes made for diabetics that are custom adjusted to take the pressure off.
So instead of going into a shoe store and buying a pair of tight shoes because you can feel them, go to somebody who specializes in something like this. Do they do that at the hospital too, or you're sending them somewhere else?
Yes, that's part of the facility.
You guys, you're both local guys. You've grown up in and around the Jersey Shore.
Correct.
And ended up in the medical profession. You were telling me you went to CBA and we graduated high school the same year.
Too bad you didn't play any sports.
Well, I don't know that Redman played CBA back then.
No, he didn't. You're a different class.
Different, yeah. And you're a Shore Regional guy.
Shore Regional, class of 80.
What brought you? Did you ever leave the Jersey Shore?
Yes, sure.
Where'd you, what, to go to school?
Yeah, I actually trained and taught in Cleveland, Ohio for a while.
Where'd you go to school?
The Ohio College of Podiatric Medicine, and I trained at the Cleveland Foot Clinic.
Was it just a desire to live in New Jersey again that brought you back
Wanted
here?
to come home, family.
That's a good reason.
Yeah.
But West Long Branch and Shore Regional.
Correct, and my wife's family's from Long Branch, so we're homegrown.
DeSantis.
Yes.
And you're
Same
an Asbury
thing.
Park kid.
Yeah, family oriented.
And with a fairly, the first thing I said when they introduced me is I said, I know the name. I mean,
Yep, the auto experts at the Jersey Shore.
and
Fahoury brothers.
that business has been there as long as Monmouth Medical Center, virtually.
Yeah, my father opened it when I was born, and remember Joel Tread down in Asbury Park?
No.
Down the radio store? He wouldn't give him a raise, so my father quit and opened up the body shop.
And you worked there for a while, too.
10 years.
Still working on bodies. Do you hear that joke all the time?
Yeah. Yeah, I'm used to it.
Do you like what you do? I mean, the medical profession is, I mean, you hear, I think you hear it about every profession, but the idea being the insurance companies and lawyers with malpractice claims and, you know, we're the bad guys frequently. It's not an easy way to make a living.
It's getting tougher, but you innately just really feel good about helping people, and you kind of try and put all the bad stuff aside. But you're correct. Between the insurance companies and the malpractice and the constant more government involvement, it's getting extremely difficult to focus on patient care.
We have patients that have seen 2, 3, 4 other providers or institutions and have been told you're going to have a limb amputated. They come to our center, undergo hyperbaric oxygen. We just had one fellow, just unbelievable, was told he had to have his leg amputated, and he's completely healed through some different modalities, grafting, and the hyperbaric oxygen. I mean, that's a direct, that's just a great, you're impacting people's lives that way.
Did you both grow up wanting to be in the medical profession?
I did. My brother's a physician. My father was a physician locally, so.
And then you just, you continued with it?
Yeah.
And you?
No, I just fell into it.
How'd you do that?
Well, I originally gotten into dental school and decided I didn't, it wasn't for me. And I just kind of expanded with that.
Glad you did?
Yeah, it's worked out very well.
Now, you know, the hospital is constantly changing. I mean, and along with the medical profession. The ability of physicians or podiatrists to be out on their own, is that getting, I would assume that's got to be hard.
It's extremely difficult.
Do you have private practices separate from the wound center, or is that full time for you guys?
No, we each have private practices.
Outside of the hospital?
outside of the hospital.
Where's your office located?
Mine's in Shrewsbury.
And yours is?
West Longbridge.
So you don't travel too far.
No, I like it here.
Well, that's a good thing. What do you see as the future of wound treatment? Where is it going to expand more? I mean, if 10 years ago, artificial or what do we call the skin?
Human skin equivalent.
Human skin equivalent.
Right.
Where is the profession going?
There's always new technologies, advanced wound care products that are coming out.
Can you give us some idea what they are?
No, not at the top of my head, because we're really pretty up to date. Probably the only thing we haven't mentioned is we also use a vacuum assist machine that helps close larger wounds, lots of times with the human skin equivalent. It's called a wound vac. It creates a negative pressure that helps close the wound faster.
What's a negative? I mean, negative.
Remember, a wound doesn't heal from side to side. It has to heal from the bottom up. So
It's not a matter of me remembering. I never knew that.
Yeah.
This is a mobile little unit, which is a vacuum, which applies pressure constantly.
So it's sucking something.
It contracts the wound.
Yeah, and actually will, absorb fluid out of it and create a negative pressure area to the wound itself that it will also facilitate healing on larger wounds or larger defects.
Does it hurt?
No.
No.
And what do? You just place it on the wound, it covers it up, and then it...
Correct.
Yeah, it's like a sponge with a tube that's connected to the machine, and it actually gets a plastic covering over that seals it. And it's very effective.
You know, people, if you had asked me what a podiatrist does, I never would have guessed any of this. It sounds a lot more involved than I think most people would think.
Yeah, we have a public identity crisis. I'll admit that. People really don't know what we do.
I would think that's true. I mean, most of the people think, I went to a podiatrist, I needed orthotics to go running.
Right.
I've been getting injured, so they gave me foot molds. But this is a whole different level of care. This is, it's no different than being a physician. Did you study this is wound treatment a big part of the course of study?
Wound treatment centers have kind of evolved over the last 10 years.
Yeah.
There were no wound treatment centers previously. Basically, all wounds were treated the same. So this kind of evolved, this whole specialty.
And
We now know how wounds heal, the biochemistry behind them, and that's just a big factor.
Is that something you studied in
well,
school?
it fell into our laps because the majority of most wounds are lower extremity. And yeah, you studied, how to heal them. In your residency, you treated them, but there were no real wound care centers per se. Essentially, we did a 4-year course after college, equivalent to medical school, and our residencies varied from 1 to 4 years, depending on our on the program. And in those programs, there was always some component of consults for wounds and infections.
And so this is the logical outgrowth of that now.
And as you get out, it's becoming more prevalent. As diabetes becomes more prevalent, the wounds become, they've evolved.
I mean, as people's weight continues to grow, diabetes become a larger problem.
Big problem.
All right. Well, thank you both very much for coming over. Learn something.
Our pleasure.
Thank you.
Thank you.